Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Dorien, it's so wonderful for you to come to this podcast. It's so great to have you on and learn from all the wonderful work that you're doing. Our plan today is to put together two podcasts, say the first one on biceps pathology, and then later we'll do one on degenerative rotator cuff tears. But before we get into that, can you start by introducing yourself to the audience? Tell us about how your physio career, how you got to be doing all this cool work that you're doing.
Yes, well, hi, Margie. Thanks for inviting me to the podcast. It's always a pleasure to talk about the shoulder, so I'm very pleased to have the chance to do so today. So as for my career and how did I end up here doing the podcast with you? Well, it started when I was graduated as a physio in 2012 at Ghent University. And I actually started working in a clinical practice. It was a private practice, not only shoulder patient, but it was a mixed patient population, so mixed pathologies, but all musculoskeletal. But then I got a call from the university again in that same year, and they said, well, we have an open position for a PhD, but it was in the low back. Would you be interested to do this job interview and to see whether or not it's something for you? So I went to that interview, but actually my passion was not in the low back. So I talked a little bit too much about the shoulder there, so I was not granted that position. But actually, that was a good thing because the year later, in 2013, I got a chance to do a PhD on the shoulder, which is more related to my interests, so with ankles. And that's where my research journey started. So during my PhD, the focus was more on the athletic shoulder, where we had or investigated three main parts. So the first part was about the kinetic chain. So we looked at differences in the kinetic chain. Does it change your shoulder muscle activity? And then second, and you are very much related to that part, was about physical performance testing. So yes, yeah, that's also your expertise and your research area. We talked about these testings a lot, also recently with the PhD of Jasper. So I'm still continuing that research line. So that's quite nice. And then the third part of that line was about biceps pathology, which is the topic for today.
Yes.
And then after finishing my PhD in 2019, I started doing a postdoc also at Ghent University. And then I switched my research area into the elderly shoulder and more about the degenerative rotator cuff tears. So that will be the topic of the second podcast. Now, during my time as a researcher, I also do teaching, so teaching of students. And I also combine it with working after hours in a private practice, mainly focusing on patients with shoulder disorders. So I really find it very of added value to combine these three aspects. So we have the teaching, we have the research, I have my clinical work. I think it's a lot of added value. So there is an exchange between these three domains, which I find very interesting.
Yes. Yeah, you must be an incredibly busy lady. There's a lot going on there, isn't there?
Yeah, there is. But yeah, you have to do something with your time, right?
Why not look at shoulders? Exactly. Let's talk about biceps pathology then. What do you think are the most common pathologies that present in clinic? What should clinicians be looking for?
Now, I think when we look at biceps pathology, we actually have to go a step back in order to understand how the pathology is originating in your patient. So when we go back to the anatomy, that's really important to get the picture right. Of course, we know that the biceps consist of two parts. So we have the long and the short head of the biceps. Now, problems occurring at the short head are very rare, so they're not that common. So I will not focus on these ones. But when we take a deeper look into the long head of the biceps and into the anatomy, then we know that the long head of the bicep originates inside the shoulder joint, so intra-articular, via the superior labrum on the superior glenoid. So that's really an important factor to consider for pathology. I will talk about it later. And then we have an intra-articular portion of our biceps tendon. And then when the bicep tendon goes from inside to outside the joint, that's a very crucial point because the biceps takes a turn about 35 to 40 degrees. And that can create a very unstable situation. But based on our anatomy, we have a very cool structure over there, which is the biceps pulley. And the biceps pulley really makes sure that the biceps tendon stays in place when going from inside to outside. So when taking the turn. So actually, you could say that the biceps pulley is like the seatbelt of the car. So when you're driving straight ahead with your car, you don't need your seatbelt that much. But when you're taking a turn or a very strict turn, then the seatbelt has to make sure you stay in place. So what the seatbelt does for you in your car is what the biceps pulley does for your biceps tendon. So that's a really important structure for stability. And then when we move from outside the joint, the biceps tendon extends more distally, goes into the bicipital groove and forms a common muscle body with a short head. And then we have the tendon again, the distal tendon with the attachment on the radius. Now, the most common disorders occur at the proximal tendon. So that's the most common one that will you encounter most in clinical practice. This is our most frequent issue. Problems with the distal tendon, so at the elbow, are less much common. So I think let's focus on that long head of the biceps tendon proximally. And actually, there's a lot that can go wrong over there. It's really an area where a lot of pathology can occur, and sometimes we do not know of the pathology, so we do not see it in practice, but actually it is there. Now, when we look at inside the shoulder joint, so the attachment on the superior labrum and the superior glenoid, if you have an injury over there, then we talk about a SLAP lesion, so a superior labrum anterior to posterior lesion. I think that's something that we can frequently see in research. I think it was hyped, like in 2012, it was a hype in that years, so they saw it, but maybe it's also a common sport-specific adaptation, so that's a very difficult distinction. And then also inside the joint, the portion of the tendon inside the joint is also susceptible for, and dare I say the word, for impingement of the long head of the biceps tendon. So it's the anterior superior impingement. It gets entrapped. There is a conflict between the anterior superior part of the glenoid rim and your humeral head. So the biceps tendon gets entrapped over there. So that's also a possibility. And then also in that area inside the joint, we have a zone, a hypovascular zone that is really susceptible for injury. And the injury that most commonly occurs over there is a tear. So if you have a biceps tendon tear, the most common site of origin is inside your joint, that part of the tendon. Now, when we move from inside to outside the joint, we have that biceps pulley. If you have a biceps pulley lesion, that of course leads to instability of your biceps tendon. So that's quite important structure. And then of course, we also have again the impingement, but then outside the joint that can happen. It's a coracohumeral impingement. So the biceps get impinged between the process coracoid and the humeral head again. So that's also not common, but it happens. And then the most common one is the tendinopathy, of course, of the biceps, which can extend over the whole tendon. I think that's the main reason why people get to the physio.
Yeah, right. It's so complex, isn't it? When you think of all those different parts, it's great to have that level of detail. I imagine that pathology in those different areas or the different types you talk about have different mechanisms. You think, like I'm
Mhm.
thinking, at the superior label, then it's lots of sort of extended. I've got my arm cocking backwards here, or that sudden hanging. Sometimes I've seen construction workers who fall. Are there any other, I guess, specifically for clinicians to think about those different areas, the mechanisms they should listen
Mhm.
for in the history? Would that help them identify that it's a biceps problem rather than rotator cuff related pain, because they present similarly, don't they? Or do they? They're different. What are the differences? How could clinicians pick that out based on mechanism or other factors?
Yeah, that's a very good question. And it's really important. Maybe we should start with that Biceps pathology actually rarely comes alone. So if
Mm,
you have a biceps problem, it's always related to another problem. And that other problem is quite often rotator cuff related shoulder pain.
mm,
Or it can also be anterior shoulder instability or a scapular dysfunction. So know that when you have a patient with a rotator cuff dysfunction,
mm,
then quite often there's also a biceps problem. Now, when we look at the history of our patients, what they are telling us, to make the distinction between both, based on location of the pain, we see in biceps pathology that's more anterior related. Specifically for slap lesions, we
mhm,
see patients actually have two different type of patients experiencing pain. The first type of patient says, okay, I have a deep shoulder pain and it's located here, deep in my shoulder at the anterior part. So it's a one specific spot. And then we
mm,
have the other patient with a slap lesion that says, I have deep shoulder pain. It's somewhere in front of my shoulder, but I don't know where. So that is the location of the pain in the anterior side of the shoulder is quite important to make the distinction, while in rotator cuff related shoulder pain, so more supraspinatus related shoulder pain, it's more proximally located, more in the
mhm,
lateral deltoid part. So that can make a distinction for clinicians. Um, yeah, then I think that that's quite important. But know
yes.
that patients like with a rotator cuff tear, the numbers are 90% of patients with rotator cuff tear also have signs of tendinopathy of the long head of the biceps
Right.
tendon,
Yeah.
and 45 have also instability of the biceps tendon. So it's really related to each other.
Yes.
Um, yeah.
And in terms of the other mechanisms that people should look for, there's the same underload overload pathology, the same, or that doesn't really exist in these. I guess I typically have thought about them as the tendinopathy, but I haven't
Mhm.
particularly thought about it in response to load or the sudden load, or how do you think these tendinopathies appear?
Yes, like for biceps tendinopathy, it's indeed related to load, but load can be expressed on different ways. So we have load based on activity, so there is too much activity for too a long period of time, or it was too much one specific event. That's also possible. So that's based on activity, but it can also be related to compression. Often it is compression with tendinopathy. So the biceps is compressed, and it can be like an impingement-like story, if you want to use that term or not. But if somehow your biceps get compressed, then it can lead to another compression load, and if it extends over time, then it can lead to degeneration and then tendinopathy and
Yeah.
eventually a tendon tear, for instance. So that's also something you can consider in your clinical examination. Um, and concerning a slap lesion, you said already the right things. It can be based on a traumatic event, so like a fall on an outstretched arm. It
Mhm.
can be related to that late cocking phase, so the extreme external rotation positions in which the biceps tendon turns on itself, so go backwards. So we have the peel back of the biceps labrum complex over there, so that can lead to a slap lesion, but it can also be more chronic. So in that peel back phase, it can be more chronic and not an acute trauma that we see. Now, also with our a tear can also be related to an acute traumatic event, but it can also be a progression from a tendinopathy eventually to too much degeneration and a tear. So it's really dependent. It's not always an acute trauma. It's not always a degenerative way of thinking. So it can really have a different mechanism for having a biceps problem.
Yes. And what do you think are the key parts of the assessment then for clinicians to pay attention to? Like, I know that I think back to the patients that I've treated for what I thought was their supraspinatus tendon, and they didn't really get better until I focused on changing their bicep. What tips have you got for us how should we know that there is a biceps pathology there? What do we need to look for?
Well, first of all, again, the isolated biceps pathology is not that common. So if you find something else, that's normal. So if you find rotator cuff weakness, that's normal, because if your rotator cuff is too weak or the rotator cuff is torn, then we get a superior migration of our humeral head. So then the biceps tendon that's over there got compressed, so it can lead to a biceps injury. So these two are interconnected. So you cannot just say, oh, it's biceps or it's rotator cuff. It's quite related. And the same with instability. So if you have anterior shoulder instability, you have that anterior translation. But what is anteriorly? That is the biceps tendon again. So it gets compressed every time. So in clinical examination, it's good to look for like rotator cuff weakness, for laxity or instability in the anterior direction. That's quite important. Specifically for your range of motion. So if you have an internal rotation range of motion deficit, so the typical GERD with the external rotation gain, that can also be susceptible related to slap lesions. But also the opposite. So if you have an increased internal range of motion, like in your passive examination, that can also be related to that entrapment of your biceps tendon. So when you're in a horizontal adduction position with an extreme internal rotation, then your biceps tendon has a conflict between your head and another structure like your coracoid process. So that can also lead to biceps pathology or can be related to that. So you have to really test that positions of a horizontal adduction with internal rotation. Does this elevate my pain in the anterior part of my shoulder, or also in the high ranges of motion? So a more full elevation, does the internal rotation, do I have a lot of internal rotation, and does this comply with my symptoms? I think that's also very important to consider. And then another pathology that is quite related to biceps is not only the rotator cuff and the anterior shoulder instability, and it makes it very difficult, but is also your scapular dysfunction. If your scapula isn't moving very well, then it can also influence your biceps and lead to compression or more loading of your biceps. So we also have to check for that. And maybe another tip for like the differential diagnosis. If you have someone in the resistance examination with a painful external rotation, but the pain is dominated in the anterior part of your shoulder, then you might think, oh, it's the biceps, but the biceps is not activated that much with an external rotation. So what is it? So then we have to really think about the infraspinatus. So maybe there are trigger points in the infraspinatus which lead to pain in the anterior part, so referred pain, and it's not related to your biceps anymore. So that makes it very difficult, but also very interesting to see whether or not the biceps is involved.
Yes. So I had two questions that lead from that. In that sort of Hawkins and Kennedy position, isn't it? You know, like with inflection and internal rotation, I'm compressing lots of things, aren't I? Like it's
Yes.
so if granted, one of them might be my biceps, but I'm loading loads of other structures under the acromial arch there. So we can't use that to distinguish biceps, could we? But we should be thinking about that, or people talk about the pain being more anteriorly, maybe.
Yes, indeed, and it's also related to their activities, but that's of course not only for biceps. But you make a good point. But the pain is indeed different. So the pain location is indeed more anteriorly, but you cannot just make the diagnosis of there's something wrong with the biceps, if that's a diagnosis already on itself, based on one specific test. So when we when we look at provocation tests for biceps pathology, most research has been done on SLAP2 lesions. And I actually let my bachelor students perform their bachelor thesis about the psychometrical properties of all biceps-related provocation tests in literature. And I really gave them a hard job because there are a lot of provocation tests available in literature. And when there are a lot of tests for the same thing, that means that none of these tests are really sufficient to diagnose a patient with that type of pathology. So I think it's really important over there that we compose a test battery that makes sense for that patient with that specific complaint. So not base our clinical reasoning on one specific test. It's always a combination of tests, and in combination with the rest of your clinical examination and your history. I think that's an important message because there is not one test that is a golden standard, not one clinical test that is a golden standard. So in terms of high specificity or sensitivity, we do not have a test that is sufficient for that.
Yeah, but making sure that it matches with the clinical history, with the other objective findings, and I think getting that cluster of information is really important in that space, eh?
Yes, indeed. Yeah, you have to, and even then, like I said, the research is mainly focused on that SLAP type 2 provocation tests, but that's only one part of what can go wrong with your patients. And I think we actually have to use our clinical sense when interpreting our tests and really think, okay, when I'm doing the speech test or when I'm doing the O'Brien's test or any other test, what is actually happening in my shoulder? And in what way is my biceps loaded? Is it because my biceps has to be activated? Is it because my labrum is provoked? Is it because the biceps has to slide into the groove and it's provoked in that kind of way? Is it because it's compressed? What is the reason why my biceps can be provoked in this test? And maybe that is a more clinical useful reasoning to use your
dig
test
down
battery.
into the detail of it, eh? Because I must admit, I typically, as a running through my assessment, doing a quick, do you have, resisted elbow flexion? I'll bring you out here into a speeds test. And if not, then I'm like, oh, okay, so that's not likely, but actually there's loads more things I could be doing to check that, but following through the mechanism and how they present. And like you say, all the different factors of the bicep would be much more thorough for me.
Yeah, it really depends on what exactly is going on and what you are exactly provoking. So you cannot say biceps pathology. That does not cover.
No, that's what I've learned from you this morning. Can you tell me then? So now I know there is a problem in the biceps. In terms of treatment, that is different for these different factors, or what? Talk to me about treatment then.
Well, indeed, I think treatment is different based on the type of biceps pathology that you have. So sometimes I often conservative treatment is a first line treatment, so that's fine. But in some pathologies, it's not. Or conservative treatment can only have a limited effect. For instance, if you have a biceps pulley lesion, then it's quite difficult to conservatively treat that patients. But then again, surgery is also not that good for those patients.
Yes.
That's really difficult to treat. But again, your treatment should be based on the specific pathology that is present with your patient, combined with what did we find in the clinical examination, what other pathologies are present, and should I target together with my biceps? So that is really difficult, interesting. But to get some ideas or main focuses, if we look at the biceps tendon itself and not the rotator cuff problem or the instability problem or the scapular dysfunction, which we also have to target, and that's really important. But when we look at the biceps tendon, I think we should take into account the irritability of the tendon. So if we have a high irritable biceps tendon, then the first thing that we have to do in the treatment is to calm the tendon down. We really have to make sure that we do not load the tendon or do not load the tendon too much, really avoid loading on the tendon with a high irritable biceps tendon. I think that's the most important factor. Now, the kind of load can be different. So we have different kinds of load that can present on the tendon. For instance, you can have a stretch or a tension type of load. So when your arm is behind your body, so in an extended shoulder position with the elbow extended in pronation, or for instance, for the slap lesion, like you said, you have the abduction with the external rotation position that we want to avoid because that will be painful and will provoke the tendon or the slap lesion in this case too much. So that's one way in which we can avoid the load. Second of all, also the compression, we have to avoid any compression in that. So if we have some type of impingement, we should avoid all internally rotated positions or too much internal rotation, so the excessive internal rotation positions. That's quite important. The same for tendinopathy related biceps problems. And then another way to avoid load is to keep the activity in the biceps low in the beginning. And that's actually why we did some research about this during my PhD. So we did two studies where we really looked into the EMG activity of the biceps together with scapular muscles and some glenohumeral muscles in order to see if we could get a staged activity level or a stage progression of exercises with increased activity levels in our biceps muscle, so that we can say, okay, in the first phase of our rehabilitation, we want to keep the activity low. We want to not provoke the biceps too much because it's high irritable. And then we can progress in the more advanced stages of rehabilitation to really load the biceps so that the patient is ready to perform the activities that they want. So that's a quite nice exercise progression that we did over there.
Yes, I remember that paper. Yes.
Yeah.
Can you tell clinicians the key exercises? So a couple of examples maybe for low load biceps, footer, the key findings from that paper, you think, for clinicians?
Yes. So when we look at the first paper was mainly focused on low to moderate load exercises, where we saw that there were common rehabilitation exercises, so the typical scapular exercises, like we have the full can until 90 degrees, but we also have the horizontal abduction with external rotation from a prone position, like these kind of exercises. And a lot of these scapular exercises that we already use in our rehabilitation are actually low in biceps activity, which means that when you have a biceps problem together with a scapular problem, which is quite common, you can do the scapular exercises without provoking your biceps too much based on activity levels, of course.
Okay.
So these exercises can be used. And then in the second paper, we looked at some exercises with more moderate to high load. And then we actually, I think it's more relevant to not just say these were the exercises, but to get the principles of the exercises, that you can use these principles in your own patients with their own story and their own activity level. But what we saw there was actually 4 ways to have increased biceps activity. And the first one was to do elevations in the sagittal plane. So this kind of movement elicit high biceps activity. And then second, and that's not surprising, of course, but to muscle-specific movements, mainly based on the elbow flexion and supination movements. And then it's preferable to not support your upper arm. So for instance, if you do an external rotation against resistance exercise, you can support your arm or you cannot. But if you're not supporting the arm, then we see that biceps activity is increasing. So that can be the case. And then the third way to have increased biceps activity is by actually contracting your biceps in a functional way. So doing an elbow flexion supination and a forward flexion, but from an extended position. So if you have the uppercut movement and you start with a neutral position, so going from the neutral into upward flexion with an elbow flexion and supination, or you do the same, but with your arm extended, so behind the body. So we have some pre-tension on that biceps. Then we see that biceps activity levels increase again. But of course, you have more tension on biceps. So that's another way to provoke load. So you have to see whether that is okay for that patient and that time. And then we have a fourth way, or explosive high velocity exercises, like with a plio ball, doing like these kind of movements. So also so in an elevation related position. So that can all be like different aspects that you can use in your rehabilitation to compose your exercise program. But really important maybe to consider here is that these exercises or these studies, these two studies that get your exercises going from low over moderate to high biceps activity is actually quite good for your clinical reasoning and to get your exercises right. But it's only based on EMG activity. So we do not take into account any other load that is coming onto the biceps tendon. So you could say that we should choose the exercise with the lowest biceps activity for all patients, because that's the exercise, that's the way to go for every patient in the beginning of rehabilitation. But of course, that exercise do not take into account, for instance, the limitations in range of motion that the patients might have and why they cannot perform this exercise. Or specific in this study, the exercise with the lowest activity was the internal rotation from the abduction external rotation position, so an internal rotation against resistance with support. But that will be painful for somebody with a slap knee. Not be the first choice based on the biomechanical load that's happening inside the shoulder. So again, it's really important to use your common sense and your clinical reasoning and take into account other factors and activity for that biceps load.
It's so wonderful, Dorien, because there's just such a level of detail that I don't think I was acknowledging. And so it's just, I really love your work in this space. Tell us about, there's a bicep course that you've put together, isn't there, for people who want to learn more about this? Tell us about that.
Yes, me and my colleague are actually doing a course. It's a 2-day course, and it's only about the long head of the biceps tendon. So it's very specific and very thoroughly about that specific aspect of your body.
Yeah, I love it.
So some people might be afraid to follow that course because it's that specific. But I hope after this talk that you will remember that biceps pathology never comes alone. So it's a more complex story. So it's not related to one specific aspect of your shoulder of your tendon. No, it's more than that. So we cover more aspects of only that type of tendon, but it's a starting point for our course.
But it's such a nice perspective to take, because obviously there's all these factors that feed into it, and like you say, it doesn't exist alone, but you have such a wealth of information there to share with people. So that's really wonderful. That is only in person, or I could do that online as well, or it's only in person for people to come?
Well, we can do webinars on request that we can do.
Okay.
But otherwise we do a 2-day course in person, because then it's
Yes.
also with practical
Yes.
examples
Okay.
for the examination and for the treatment. So it's also quite practical, and we really
Yes.
give some practical advice and with some cases from real patients.
Yes.
So quite
Wonderful.
interesting
Yeah, I
to.
bet. I bet. Do you have any closing remarks about biceps pathology? What do you want clinicians to really think about when they see patients?
Um, well, I think the differential diagnosis should be taken into account.
Yeah.
So look at rotator cuff dysfunction, make the distinction, if possible, between both. So the anterior shoulder pain versus the more proximal or lateral deltoid related shoulder pain.
Mm,
Another thing, look at the infraspinatus and trigger points that can lead to
yes.
anterior shoulder pain, that it's not biceps. So
Yes.
that's also quite important. Yeah. So it quite never comes alone. I think that's the
Yeah.
main message I want to give
Yeah.
to
That's
people.
wonderful. And then clinicians should treat all those other factors, and then in conjunction maybe with some biceps related specific treatments as well, eh?
Mhm.
Yeah.
Indeed, yes.
Yeah, cool. Hey, well, thanks very much for your time and for sharing your expertise. It's been wonderful.
Thank you, Margie. It's been a very good opportunity. Thanks.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.